Hello, everybody. Greetings from Pathkind, a unit of mankind. मैं Dr. K.K. Agarwal, President, Heartcare Foundation of India. I welcome you all in this platform. In a series of our sessions we are doing, this is going to be for me, it is going to be 2,220 85th session, 2285th session, non-stop I'm doing. And for Pathkind, this is going to be our session number 11. So the series of lectures we are doing, basic objective is to create awareness about diagnosis, molecular understanding, and we have been focusing on two things. We have been focusing on COVID, and we have also been focusing on tuberculosis. Today I have with me Professor Ashok Ratan, who is a Commonwealth Fellow, who is a CRO temporary advisor, who is a WHO lab director to CARAC and PAHO. He is an advisor to Pathkind Labs, Knowledge Forum, R&D and Quality, former in the faculty of All India Institute of Medical Sciences, a teacher for excellence. And the subject we are discussing is diagnosis of tuberculosis in the children. Often a difficult diagnosis in the past, but now with newer tests available, it is going to become easier and easier. Let's listen to Professor Ashok Ratan. All yours.
Thank you, sir. That since its discovery in 1882 by Robert Koch that it was a bacteria that causes tuberculosis, tuberculosis has claimed more than 1 billion lives, which is more than those who have died because of malaria, smallpox, HIV/AIDS, cholera, plagues, and influenza. If we ask ourselves how many children have died, nobody seems to know. There was a mathematical modeling which was published in Lancet, which indicated that it appears that in 2015, 2,39,000 children had died of tuberculosis. 80% of those children were below 5 years of age, and most of them were not on anti-tuberculosis drug because it was not diagnosed in them. Many more were on ATT when in fact they were not suffering from ATT, not suffering from tuberculosis. So there's a huge opportunity to make a difference in childhood tuberculosis. The Stop Tuberculosis Program and WHO then worked out a roadmap for childhood tuberculosis and how to move from so many deaths towards zero death. And out of the 10 steps that they wanted to take, the 7th step is what we will discuss today. That is how to scale up child and adolescent TB case finding and treatment. If we understand the natural history of TB in children, and especially looking at what used to happen before BCG vaccinations, in the era before BCG vaccination, we would find that tuberculosis in children had 5 phases. Phase 1 occurred when the bacteria enters the child's body, and it is between 3 to 8 weeks after primary infection. Thereafter, there would be phase 2, which will occur 1 to 3 months after phase 1, where the bacteria will migrate to other parts of the body via the blood and represents the highest period of risk for development of tuberculous meningitis and miliary tuberculosis in young children. In phase 3, there would be pleural effusion in children older than 5 years and bronchial disease in children less than 5 years of age. Subsequently, there would be phase 4 when osteoarticular tuberculosis in children within 5 years or less would occur. And the 5th phase was 3 years after the primary infection, where calcification is completed and features of adult TB starts appearing. If we look at it another way and relate it to bacterial load, first there is TB exposure. TB infection can start with exposure to 3 bacteria. Only 3 bacteria can cause infection. Once infection has occurred, then it'll proceed on to subclinical intrathoracic TB, which will then proceed on to non-severe intrathoracic TB, and finally intrathoracic TB. The bacterial load, as I said, infection occurs with 3 bacteria. There will be subclinical intrathoracic with 10 to 100 Mycobacterium tuberculosis. Non-severe infection would be at least 131 bacteria, which is the sensitivity limit of Gene Expert, as we'll discuss later. Then when severe infection occurs, it's 1,000 bacteria, and smear sensitivity is 10,000 bacteria. So a child would have to be very severely ill for the disease to be recognized by doing smear examination, because smear examination needs 10,000 bacteria to be present. On the y-axis, as you notice, that initially there is no disease. First, then it will be asymptomatic, where we now call that as latent tuberculosis. And finally, it will become as overt infection or disease. So there's a continuum. The problem with the main diagnostic challenge and the problem is that first is infection, differentiating between TB exposure without infection and TB infection is sometimes difficult. Then is disease, detection of TB disease, of drug resistance. Currently available tests of bacteriological confirmation have limited sensitivity. And finally, we have trouble with monitoring of the infection. So the problem at the moment are plenty, but I hope that by the end of this talk, we would have appreciated that there is 4th generation interferon gamma related release assays, which will help differentiate between latent tuberculosis and active infection. There is Gene Expert Ultra, which will detect 16 bacteria in the sample. This is so sensitive that instead of doing gastric lavage, as children have a habit of swallowing their sputum and do not produce sputum, they do not expectorate sputum. So stool could be examined rather than trying to get gastric lavage from them. And then by serially examination of interferon gamma produced in the 4th generation IGRA test, we could then see whether a person is responding to the treatment or not. We understand that active tuberculosis is as a consequence of exposure to the bacteria and modulation of innate and adaptive immune response, in which genetic susceptibility, BCG vaccination, immune system maturation, nutrition, and co-infection all play a role. TB disease in children, the clinical epidemiology is that most of the cases occur in young children, less than 5 years of age, and most disease occur within 2 years of exposure. Majority of them in first year. The risk of infection translating into disease are maximum in the first year of exposure and subsequently keep on decreasing. And most cases are as pulmonary tuberculosis, though extrapulmonary tuberculosis can also occur which is either as tuberculous meningitis or as miliary tuberculosis. In the first year, as you notice here, TBM and miliary tuberculosis plays a major role, and subsequently it is pulmonary that would occur. When they looked at caseload of childhood tuberculosis in Malawi, they found that 30% of children would have extrapulmonary tuberculosis. When you compare in Malawi as well as in Papua New Guinea, then the extrapulmonary tuberculosis could be lymphadenitis, pleural effusion, spinal infusion, pericarditis, abdominal, miliary, meningitis, bone marrow, and as you notice that in Malawi, in Africa, it's pleural effusion and spinal, which is next only to lymphadenitis. And in Papua New Guinea, lymphadenitis was most prominent, followed by abdominal and meningitis. In 2014, WHO took out a manual saying that diagnosis of tuberculosis can be made with confidence in majority of children using careful clinical assessment. They also wrote that it is difficult to confirm diagnosis of TB in many children, but it is usually not so difficult to make a clinical diagnosis of TB in a child. In the same manual, they said what we should do is take careful history, including history of TB contact and symptoms consistent with TB. Next, follow up with clinical examination, including review of growth chart. Then they suggested that in poor countries, we should do tuberculin skin test, but in richer countries, IGRA could be done. Chest X-rays in 2014, they said it could still be done if available. Bacteriological confirmation whenever possible was what was their suggestion, and investigation relevant for suspected pulmonary tuberculosis and suspected extrapulmonary tuberculosis should also be done. And they indicated that HIV testing should be done whenever we suspect tuberculosis in children. The key risk factors identified were household or other close contact with a case of pulmonary tuberculosis, age less than 5 years, HIV infection, and either weight loss or failure to thrive. Then FIND, which stands for Foundation for Innovative New Diagnosis, which is a branch of WHO, undertook a study in India looking at laboratory diagnosis or molecular diagnosis of tuberculosis, in which CBNAT, which is another name for Gene Expert. CBNAT stands for cartridge-based nucleic acid amplification test, was carried out in 10 different cities in India. And during that study, 94,415 samples were taken and 6.6% was found to be positive, out of which 545 were rifampicin resistant. They found that positivity rate was higher in females than in male child. And out of the 1 lakh samples that they tested, about 50 of them were non-sputum. When they looked at only AFP smear examination, they found that only 2% were positive. And to the benefit, 89% which were diagnosed by using this method could be linked with treatment. So, National Tuberculosis Elimination Program now mandates upfront that gene expert should be done for diagnosis of pulmonary tuberculosis. This is to indicate that samples from all sites were taken, the relevant samples, and recently WHO has taken out a rapid communication which says that gene expert, that is expert MTB RIF, as a replacement for sputum smear microscopy. So instead of doing smear, we should do gene expert should be the first test to be done. The sensitivity was 85%, specificity was 98%. Gene expert, as we discussed last time also, it is a cartridge-based test. The cartridge is a self-contained molecular biology lab. All that is required is 2 ml of sample to be placed inside. Then in 90 minutes time, it will give two results. One, the result will indicate whether the patient has Mycobacterium tuberculosis or not. So this test is a molecular biology test. It's a PCR test which will detect whether genes specific for Mycobacterium tuberculosis are present or not. And the second question, it will also give quantification. As you notice, the quantification is in semi-quantitative manner, which says high, medium, low, very low. And this is related to the CT values in which the test became positive. And along with the quantity of Mycobacterium tuberculosis present, it would also indicate whether there is any mutation in the area which codes for rifampicin resistant. And rifampicin resistant was initially thought to be a surrogate marker for MDR tuberculosis. So using this test on pulmonary samples or extrapulmonary samples, in 90 minutes time, we can get two results. One, whether Mycobacterium tuberculosis is present or not present. Second, whether rifampicin resistant is present or not. The limit of detection is 131 bacteria per ml. Now, this is a gene expert is manufactured by CIFET, which is based in USA, and they had made one submission to the US FDA saying that for diagnosis of pulmonary tuberculosis, smear had a sensitivity of 30% and culture had a sensitivity of 100%, but it will take 6 weeks. While gene expert had a sensitivity of 99%, a specificity of 99%, and a turnaround time of 2 hours. So in 2 hours time, you would be able to find out whether you are dealing with a patient suffering from from tuberculosis and whether this is MDR tuberculosis or not. This was then approved by US FDA and taken over by WHO. And WHO commissioned many other studies which all indicated that it had high specificity, that it will be, when it detects Mycobacterium tuberculosis, it is Mycobacterium tuberculosis that a person is suffering from. In 2010, they made a policy statement, and in 2013, they made an update saying that all adults and children with signs and symptoms of tuberculosis should be offered this test. This was to replace the slow-growing culture method, where breadcrumb kind of colonies would grow, but this would take weeks before they become positive, and they were of low sensitivity, which was to be replaced by a tube known as Mycobacterium growth indicator tube. Midget tubes are liquid medium with an indicator at the bottom. The indicator is non-fluorescing as long as oxygen is present. Once the bacteria grows and it has consumed the oxygen which is present in the medium, the bottom of the tube will then fluoresce orange when exposed to ultraviolet light. This Bactec Midget 960 is an instrument which has 960 wells, and each well has a probe at the bottom which will be able to give out ultraviolet light and be able to see whether orange fluorescence is there. This is then regularly monitoring. Once the sample is placed inside the liquid, then as long as the culture is incubated at regular interval, there'll be monitoring of growth of fluorescence or not, and whether fluorescence is present, that will be monitored, and the moment that is detected, and this happens 24/7, the moment it is detected, it will flag the tube as positive with sound as well as light. As a consequence, they will lead to early detection. When Dr. Bansidhar nowadays is in Max, when Dr. Bansidhar and I were both in SRL, we had taken 500 consecutive samples and subjected them both to LJ as well as midget. And we found that in the first week itself, many of them were positive. While LJ took at least 2 weeks to grow and were less sensitive. 391 out of 500 were positive by culture using midget. And as you notice here, it was positive much earlier than smear exam, than by LJ method. So midget is the preferred method, is the new gold standard for diagnosis by culture. The advantage of midget is that Gene Expert will give you results in 2 hours time, but it can answer only 2 questions. Any additional questions you have, you would have to have Gene Expert to be able, you would have to have culture to be able to address any additional questions that we might have. Then it was also noticed that not only for smear positive pulmonary tuberculosis, but even in smear negative pulmonary tuberculosis or in extrapulmonary tuberculosis also, Gene Expert was the best method that was available. Dr. Camila Rodriguez in Hinduja Hospital took a number of samples from extrapulmonary tuberculosis and reported the same, that the sensitivity was much better than any other method available. So though Gene Expert came to be used as the best method for tuberculosis, it was later on found that wherever there is paucibacillary, wherever the number of bacteria are low, especially in tuberculous meningitis, in endometrium or in pediatric infections in particular, especially pleural fluid. In that case, gene expert was not as good as, it was the best that was available, but not as good as you would have wanted. So one of our students who did PhD in All India Institute then went on to manufacture, then to devise the Gene Expert Ultra. Gene Expert Ultra is a more sensitive cartridge compared to Gene Expert. This cartridge can detect 16 Mycobacterium tuberculosis as opposed to 131, which could be previously detected. And they have made changes in the PCR. So instead of one PCR, there are two PCRs, and they are looking at the size is the same, but 20 instead of 25 microliter, 50 microliter are used in the reaction. With the use of Gene Expert Ultra, the sensitivity became more for detection of Mycobacterium tuberculosis in children. And as I indicated, that even stool samples could be used after differential centrifugation for detection of tuberculosis, pulmonary tuberculosis in children. And in another study where they compared Gene Expert Ultra, and culture, they found that Gene Expert Ultra was the most sensitive of the three methods. So after direct demonstration, the other method is indirect evidence. In indirect evidence, we make use of either humoral immunity or cell-mediated immunity. It became clear that though copious amount of antibodies are produced during tuberculosis, the antibodies have neither diagnostic nor therapeutic use, while cell-mediated immunity is useful. So after a meta-analysis, WHO as well as Government of India have banned the use of antibody tests for diagnosis of tuberculosis. And no good lab would now use antibody test for making the diagnosis. On the other hand, analysis indicated that bacteria, after they cause infection, are held in check by an efficient cell-mediated immunity. It is the level of cell-mediated immunity which determines whether a person dies only with tuberculosis, suffering from a latent tuberculosis, or the immunity goes down and active infection, which can be transmitted, results. So it is cell-mediated immunity which is important, which has both diagnostic and therapeutic use. The diagnostic part of cell-mediated immunity is used by pediatricians in the in vivo test, which we call as Mantoux test. In Mantoux test, PPD is injected under the skin, which will lead to attraction of lymphocytes, which will produce TNF-alpha, interferon gamma, and IL-8, and leading to swelling at the site of infection in 48 hours time. The same thing has been applied in vitro for what is known as quantiferon gold test. And the fourth generation test is known as quantiferon gold plus. In tuberculin test, as I indicated, it is injected, PPD is injected under the skin, and then after 48 hours to 72 hours, the induration is seen. But it was noticed that PPD, though it is, PPD stands for purified protein derivative, it is neither purified nor all protein. A paper in Indian Journal of Medical Research indicated that there are as many as 132 protein antigens in what we call as PPD. And a, a, a paper in Pediatrics indicated that he argued for the case of retiring tuberculin skin test. If you retire tuberculin skin test, what you need is something which is more specific. Because tuberculin skin test had too many antigens, once we reviewed the antigens which were specific to Mycobacterium tuberculosis, then it appeared that early secreted antigenic target 6, ESAT6, and culture filtrate protein 10, CFP10, were present only in Mycobacterium tuberculosis and not present in BCG strains. So the cross-reactivity that will give false positivity with tuberculin test could be avoided if we use ESAT6 and CFP10. And this was the basis of the third generation quantiferon gold TB test, which is in-tube test, but it would detect only whether a person has latent tuberculosis or not. Subsequently, the fourth generation quantiferon gold test has been devised, in which they have two tubes in which which TB specific antigens are present, both ESAT6 and CFP10. But it was noticed that these antigens will be presented by long peptides to CD4 cells, and short peptides will present it to CD8 cells. So if we wanted to study the activity of CD4 as well as CD8 cells, then the long peptides for CD4 and short peptides for CD8 would be useful. And this was already indicated by Rousseau in 2011 that Mycobacterium tuberculosis specific CD8 cells are functionally and phenotypically different between latent infection and active disease. And she had mentioned that CD8 cells are active when bacteria is multiplying. This was then published, combined use of Mycobacterium tuberculosis specific CD4 and CD8 T cells response is a powerful diagnostic tool of active tuberculosis. And it appears that CD4 is important for keeping Mycobacterium tuberculosis in check. And that we knew since 1980s, when CD4 numbers will decrease as a consequence of HIV infection. But it was only in 2011 that we came to know that if CD8 cells are active, that would mean that they have been specifically activated to produce cytokines and cytotoxicity to kill infected intracellular Mycobacterium tuberculosis. And so it's been suggested that tuberculosis is a continuum. CD4 is required for latent tuberculosis as well as is there even in active tuberculosis, but CD8 is activated only when Mycobacterium tuberculosis is multiplying and inside the cell and is causing disease. So CD4 will be an indicator of latency, while CD8 is an indicator of activity. And this quantiferon gold TB plus indicates 4-tube test is the fourth generation IGRA test, which uses two specific antigens of Mycobacterium tuberculosis and investigates whether only CD4 is active or both CD4 and CD8 are active. And if CD8 is more active, then it would indicate that there's active infection. And we are calling this as TB Sure to differentiate it from 3-tube test, which has now become obsolete and has been withdrawn in many countries. QIAGEN, which makes this test, indicates that the specificity for diagnosis of tuberculosis is 98% and the sensitivity is 95%. And it is this difference between the TB1 tube and the TB2 tube which indicates the involvement of CD8, and the higher the involvement, the more is the activity of tuberculosis. This test has been approved by US FDA, is approved by American Association of Pediatrics to be used in children. It's also been approved by WHO, and they recommend that the 4-tube test, the quantiferon Gold Plus, should be used for finding out about tuberculosis. Now, tuberculosis is best detected by using an algorithm, and I have simplified the algorithm by saying that in case you have a patient whom you suspect as suffering from pulmonary tuberculosis or extrapulmonary tuberculosis, the first question you have to ask yourself is, can you collect and submit a sample which is likely to contain the bacteria? If the answer to that is yes, then Gene Expert Ultra with culture, which we call as Gene Expert Ultra combo, is the best method for detecting the bacteria. If you want, you can do smear examination, and if smear is positive or if culture is positive, then line probe assay 1 or line probe assay 2 could be used for finding out rapidly, that's within 48 hours to 72 hours, whether you're dealing with MDR or XDR bacteria. If, however, you are unable to collect the sample or collect the relevant sample, then 5 ml of blood in lithium heparin tube would indicate, after incubation with the 2 specific antigens of Mycobacterium tuberculosis, whether CD4 is activated or both CD4 and CD8 is activated. If CD4 is activated, then it is latent tuberculosis. If CD8 is higher than CD4, then it will mean that is active tuberculosis. Finally, whenever you're dealing with tuberculosis, please do not forget to test for HIV, because sometimes HIV is one of the conditions which makes tuberculosis overt. I think that's all that I had to say for tuberculosis, sir.
Go back to the second last slide. Second last slide. Second last. Yes, we'll spend time here.
Yes, sir.
This algorithm will be true for any age?
Yes, sir. This will work for any age.
So when you say submit sample, no, go back. Can you keep the slide there for some time?
Yes,
so can you submit the sample likely to contain Mycobacterium tuberculosis? Let's define the samples.
So the ideal sample in children could be sputum, but they don't produce sputum. So that is why in the past we used to do a gastric lavage. But as I tried to indicate, that the program indicates that maybe they should be induced sputum. But for induced sputum, you need a space which is negative, under negative pressure. Otherwise, the operator will get infected. So it is true that induced sputum may be more sensitive than stool examination. But one of the easier method for identifying infection in children would be doing their stool examination under the principle that the child will swallow his sputum. The sputum will lie in the stomach for some time. So that is where we used to do gastric lavage. But if we wait for the morning, then the bacteria would have passed out in the sputum and from in the stool. And now that we can detect 13 to 16 bacteria per gram of stool, we should be able to pick up, we should be able to identify.
So
And
how do we collect the stool? They have to collect a bottle from your center?
sir, this could be in any container, because again here we're looking for only Mycobacterium tuberculosis sample, the genes of Mycobacterium tuberculosis. This is the only exception in which I say that culture may not be useful, because stool has too many extra bacteria which will then contaminate, or we will not be able to decontaminate the stool. So in that case, we are looking only for genes of Mycobacterium tuberculosis. What we do is we take 1 gram of stool, mix it with 10 to 15 ml of normal saline and make a slurry. Once it has been dissolved, once the suspension has been made, then we put 2 ml of xylene in it and shake it. Xylene is a lipid solvent. So when it rises, and we leave it undisturbed for 15 minutes. When we leave it undisturbed for 15 minutes, xylene will rise to the surface and it'll be able to extract the lipid soluble Mycobacterium tuberculosis into that layer. So it will come, the Mycobacterium will be in the layer, and then we take the 2 ml of xylene and put that into the cartridge, and cartridge will give us positive reaction.
So what about urine? What about
So urine, of course, what we do is urine will centrifuge, then we'll use the centrifuge.
So in children, urine can also be used in which condition?
In case you suspect that child is having involvement of the kidneys, it's not as common. It's actually,
so at this moment in a child, suppose he has a lymph node, we take a FNSC, or he has a pleural or a pericardial effusion, then directly we can send.
Yes, sir. In FNAC, we indicate that they should send us whatever sample is available, and we'll do culture first. First, we'll put whatever material that comes, whether it is 100 microliter or only in the needle or more, and we'll put that into the midget medium. And then we will take 2 ml of the midget and put that into Gene Expert Ultra.
So we have done that. Now we come back to the CD. Now I'm still in the sample. Can I simultaneously should also send it for COVID?
So COVID, actually, we have not done enough. Of course, CTD, the Center for TB Division, had indicated that every tuberculosis patient should be checked for COVID, and every COVID patient should be checked for tuberculosis. But I'm not sure that there is any, because COVID is an acute disease and tuberculosis is a chronic disease. Now, it is possible that a person who has tuberculosis may be made worse by COVID. But besides that, yesterday I was reviewing my results that the number of samples last year around this time had decreased, drastically decreased. But that is because everybody started staying indoor. But otherwise, once they picked up, then there were not more tuberculosis samples.
Now, coming back to the latent tuberculosis and the recent exposure of that, where we are using a blood test.
Yes, sir.
Now, what are the indications for that?
So that, as I indicated, that you feel that the child or the adult has tuberculosis, but either it is in such a site that you cannot take the sample, or it's not, there's no localizing sign. In that case, this 5 ml of blood in Letrim heparin vial is taken. In the lab, 1 ml is put into all the 4 tubes. There are 4 tubes to be used. One is without any antigen. Second is with pork-wheat antigen, which is a positive control. And the other 2 are TB1 and TB2. TB1 will have ESAT6 and CFP10 along with long peptides, and TB2 will have the same as TB1, but along with that, it will have short peptides so that it can present the antigen to CD8. After 24 hours of incubation, the supernatant is taken, and then interferon gamma is assessed in the supernatant. Now, if it is more than 0.35 international units per ml, that means it is positive, if either of the 2 tube is positive. So first we look at whether the positive control is positive. If positive control is positive, that means the cells were living. And if negative control is negative, that means that there is no interference by non-specific interferon gamma. So once
is it a specific test for TB or it is a non-specific test?
Sir, these are it is specific for TB because the antigens are TB related, but there is not 100% correlation in the sense that depending upon immunity, sometimes you will find that the CD4 is active, but CD8 is actually, what you expect is that CD8 should always be higher than CD4 in case the bacteria is multiplying. In some cases, it is not as clear cut, but I guess you should use this as additional information that if both tubes have same levels, then it is latent tuberculosis. If second tube is more than the first tube, how much more is debatable. But
is this test approved by the WHO? The blood test, the gamma interferon?
They are using this as an indicator of TB exposure.
Okay.
Needing treatment.
So why can't we use this technology for COVID? Because we can also get CD4 and CD8 and vaccine.
So they have, I think they have made the test available in the rest of the world. They are using it. Kaizen said they were licensing it in India. They had to register it in India. They had sent me information that this could be used as a CMI for COVID. So
if you use the antigen of the COVID and if you check CD4 and CD8,
yes,
you should be able to get the cellular response in even COVID vaccine.
That's very right, sir. So that they have the test available, both Kaizen as well as Euroimmune. Euroimmune has an ELISA system, while these people have the same. They have this system, Quantiferon TB Gold, now Quantiferon COVID test.
Quantiferon TB
so
Gold,
that is there. That is available, and I guess as we grapple with what is the immune relate of protection, maybe more will be.
So let
this
me
test will be used
sum up
more
by
frequently.
saying that PathKind, the way they are working and the way they are educating all of us, I think in immunology, they are you can't have a parallel lab like that. So they have all the answers for tuberculosis. Last time also we learned that there is nothing like gene expert now. You go for ultra gene expert. The cost is the same. The technology is available. And if you want all the solutions, last time we also gave you the numbers. You can call that numbers. You will also get a consultation from them. And now we have talked about if you have a doubt in pediatric tuberculosis, you can go for a stool checkup, and you can also go for a CD4, CD8 response in children and adults in the blood test. When we know that we have to eradicate tuberculosis, we need a complete workup. Government is doing its job, but it becomes our responsibility in the private sector to make sure that we are also updated in our knowledge, and we are also updated in our diagnostic evaluation, and we understand all about molecular diagnosis. There was a time we used to say, test kara lo, but now COVID has taught us the CT value. You can see here the CT value in tuberculosis is as important. That if you have any doubt, call Pathkind. Can you have the number? Can you give the number again? Your last time you gave a number of the toll-free number.
So I'll send it up. I
Okay.
don't know.
So that number is available, and you can call them. One of the doctors from there will answer you back. Now, these types of subjects are difficult subjects. Even for me, it is difficult subject because we were never taught molecular biology in great detail as COVID has told us to learn. Watch this video again and again. This video we were live. And if you have any questions, ask us. We will be back. I will be back with Professor Ashok Ratan with one more seminar. And I've also promised you, at least in one seminar, I and he will come back to the salient points of all the seminars we have done so far, so that all of you can revise in one particular session. Thank you very much. Keep watching us. Keep waiting for our seminars in future. Namaskar.
Namaskar.
बंद करो रितु. रितु लाइव को बंद करो.